Hello everyone, myself Dr. Tarun Parmar. Today's topic is Avsd types and assessment. So what is Avsd? Avsd is atrioventricular septal defect. It's a group of anomalies that share a defect of the atrioventricular septum and abnormalities of the AV valve. So similar terms are AVCD, endocardial cushion defect. So what is the incidence? That is 4 to 5% of all CHDs and estimated occurrence is 0.19 in 1000 live birth. The total incidence of CHDs are 5 in 1000, and among the 0.19 in 1000 live birth is the AVSD incidence. There is slight female preponderance, and there is a significant association with the Down syndrome. So 45% of the children with Down syndrome have CHD. Among them, 45% have AVSD, and 50% of the patients with AVSD have Down syndrome. So what are the types of AVSD, or you can say nomenclature? So that is partial and complete. So partial is there is primum ASD is always present, and there are two distinct but focally contiguous right and left AV valve annuli. And in complete AVSD, primum ASD and contiguous with the inlet VSD, and then the common AV valve has single annulus. And there are subtypes of AVSD. These are transitional AVSD. This is the subtype of partial AVSD. If the partial AVSD has a small inlet VSD or restrictive inlet VSD, partially closed by the dense caudal attachment to the ventricular septum, is known as the transitional AVSD. The hemodynamically it is like partial AVSD, and one is intermediate AVSD, that is a subtype of complete AVSD. That is a distinct right and left AV valve orifice, but only one common annulus. So there is a tongue of tissue that is separating the AV valve orifice. So orifice is 2, but annulus is 1. VSD is large, similar to complete AVSD. So this is the cartoon representation of the types of the AVSD. So here we can see the similar physiology or hemodynamics in complete and intermediate varieties of the AVSD, where it actually behaves like VSD and ASD. So there is a large inlet VSD and large ostium primum ASD. Here also large ostium primum ASD and large inlet VSD. While the transitional and a partial AVSD has a similar physiology or hemodynamics as the large ASD. So there is large ASD, there is very restrictive inlet VSD, that is restricted by the dense caudal attachment, and in the partial AVSD there is only large ASD. So here the AV valve anatomy is similar in partial, transitional and intermediate AVSD. There is two different orifices in all these three, and there is single orifice. So in terms of orifice, common AVSD has single orifice but and single annulus, while this two has, like transition partial AVSD has two different annuli and two different orifices, while intermediate has single annuli and two different orifices that is separated by the small tongue of tissue. So here we can see in terms of like annuli and AV valve orifices, complete AVSD has one annuli and one AV valve orifice, and VSD is large, while intermediate, transitional and partial AVSD has two AV valve orifices that is been separated by the tongue of tissue, and partial and transitional AVCD has two annuli, but intermediate AVSD has one annuli. But in partial AVSD there is no VSD, transitional AVSD there is small or restrictive VSD, and intermediate and complete AVSD has the large VSD. So anatomic features shared by the all AVSD. So what are these? So AV valve leaflet insert at the same level as the cardiac crux. So we are going to see what is that. Then there is a common atrioventricular junction, and then there is absence of the AV septum, atrioventricular septum. There is an anterior displacement of the aortic valve, so that the aortic valve become unwedged or sprung. There is elongation of the LVO2, that is because of the sprung aortic valve and because of the scooped out inlet ventricular septum. There is counterclockwise rotation of the LV papillary muscle. Normal LV papillary muscle in normal heart is situated at 4 o'clock and 8 o'clock, partially that position, while in AVSD that is rotated counterclockwise, and it is now like roughly 3 and 5 p.m. position. There is cleft AV valve component directed toward the interventricular mid portion of the interventricular septum. So this morphological specimen, here we can see the atrioventricular septum. So atrioventricular septum that lies between the right atrium and the left ventricle. So it is bound above by the interatrial septum and below by the interventricular septum. So this is practically absent in AVSD. So what happens? There is a normal offsetting of the mitral and tricuspid valve. So septal tricuspid leaflet is attached more apically and mitral valve leaflet is attached more basally, and there are two distinct, you can see there are two distinct AV valve junction, but in the complete AVSD or AVSD there is single atrioventricular junction. That is junction is like histopathological differentiation between atria and ventricle. So here is the embryogenesis of the partial and complete AVSD. Normally, so what happens in partial AVSD? There is incomplete fusion of the superior inferior endocardial cushion resulting in the cleft in the mid portion of the left AV valve, and complete AVSD there is lack of fusion between the superior and inferior cushion with the formation of the separate anterior and posterior bridging leaflet, or you can say the superior and inferior bridging leaflet. It is said that every fetus is born with a complete form of canal, and then it will like differentiate into either normal. If there is a problem in the differentiation, then it will lead to the partial or complete AVSD. So here is a normal mitral orifice. This is a normal tricuspid. It is trifoliate normally. Mitral is normally bifoliate. It is a slit-like, and you can see in partial transitional or complete intermediate AVSD there are two distinct orifices, and the normal mitral valve is now trifoliate into this. So there is invariably presence of mitral valve, left AV valve cleft in all of these patients. And there are 5 different types of leaflets that we are going to see in the next slide. So what is another association is elongation of the LVOT or gooseneck deformity. So that is because of the deficient ventricular component of the atrioventricular septum and sprung atrioventricular junction. So distance from the LV apex to the posterior left AV valve is 20 to 25% shorter than the distance from the apex to the aortic annulus. So here is the echocardiographic and carto representation. You can see the distance between the apex to the left portion of the mitral valve leaflet, and this is the distance from the apex to the aortic valve. The above image shows, the upper image shows the normal inlet and outlet portion are the same, while in the atrioventricular septal defect normally because of the scooped out interventricular septum there is a VSD. This will lead to the inlet portion is 20 to 25% shorter than the outlet portion, and the distance is more in this. So this will lead to the LVOTO in post-op patient. So there is a de novo LVOTO in this patient. It may not be present during the initial thing, but it may progress, or it may it may de novo comes up after the surgery. So this is very important. So comes to the partial AVSD. So what is the pathology? Right and left AV valve annuli are separate. Primum AST in cleft left AV valve in the left AV valve anterior leaflet. Primum ASTs are large and located anterior and inferior to the fossa ovalis. There is scooped out appearance in the inlet ventricular septum, and there is a cleft in the left AV valve anterior leaflet is directed toward the mid portion of the ventricular septum. So what are the clinical manifestations? These are more or less like large ASD. So there is an increased pulmonary blood flow. It will lead to the poor weight gain or recurrent infection, but may or may not be asymptomatic. Patient may be asymptomatic until adulthood. Usually more symptomatic than the patient with the second ASD because there is association of the AV valve regurgitation. Second heart sound is widely split and fixed during the respiration, just like the large ASD. There is systolic ejection murmur that is based over the left upper sternal border ready to the lung field, and there is hollow systolic murmur owing to the mitral regurgitation, and there is low pitch mid diastolic murmur that is due to the increased blood flow through the AV valve. Echocardiography is the mainstream diagnostic modality. So the most important feature is to identify the internal cardiac crux. That is the most consistent echocardiographic imaging landmark. The apical 4-chamber view clearly visualizes the internal crux. The AV valve is placed toward the ventricles with the septal portion inside at the same level onto the crest of the interventricular septum. The two separate AV valve orifices are equidistant from the cardiac apex. So here is the pictorial representation of the internal cardiac crux. So in the normal, this is the mitral and tricuspid leaflet there is a normal offsetting. That means the septal tricuspid leaflet is more attached toward the apically, and in the AVSD, in the second image, you can see these are at the same level, they are attached at the same level. So this is the morphologic and echocardiographic representation. The top left image is showing morphological specimen of the partial AVSD. There is RA-RV dilated. You can see the RA and RV is dilated. There is a large ostium primum ASD. RV is hypertrophic, and the internal cardiac crust at the same level. The both leaflets are inserted at the crest of the interventricular septum at the same level. This is the same echocardiographic representation of this specimen. This is apical 4-chamber view. You can clearly see this is RA and RV is dilated, large ostium primum ASD. There is associated maybe ostium secundum ASD, and RA and RV is dilated, RV is hypertrophic. This is the Doppler interrogation, and it shows ASD is shunting left to right. Here is the systolic image of the same thing. It shows a moderate AV valve regurgitation. This is again the echocardiographic representation. This is a systolic image. This is a diastolic frame. In systolic frame, you cannot very well appreciate the ASD, but in diastolic frame, you can clearly appreciate the ostium primum ASD. And here is a short axis view showing this is a cleft in the left AV valve. This is a Doppler integration showing the moderate regurgitation from the cleft in the AV valve. So here we can clearly see the cleft in the left AV valve. So this is the morphological specimen. You can see there is a cleft in the left AV valve. This is echocardiographic representation. This is a subcostal short axis view. You can see this is the superior and inferior bridging leaflet. This is the mural leaflet, and this is the cleft in the left AV valve. This is directed towards the mid portion of the interventricular septum. In the normal mitral valve, if there is a cleft, then it is directed toward the LVOT. So here this cleft is directed towards the mid portion of the interventricular septum. This is a TEE image of the transitional AVSD. So here you can see there is a septal tricuspid leaflet, and there is very restrictive inlet VSD. So what are the other left AV valve abnormalities? So commonly both the partial and complete, common with the both and partial and complete AVSD. So cleft in the left AV valve that lead to the AV valve regurgitation. There is parachute-like left AV valve if there is only one single papillary muscle or very closely placed papillary muscle, then it will lead to the parachute-like left AV valve. And there might be double orifice of left AV valve. This can happen in 3 to 5% of the patients. So what is the importance of this parachute-like mitral valve and double orifice left AV valve? This will lead to the post-operative stenosis of the left AV valve. So this is the echocardiographic representation of the same. Here you can see the cleft in the left AV valve, and here you can see the double orifice of the left AV valve. So what is a sprung AV valve? So sprung AV valve, normally what you can see, the aortic valve is located wedged in between the two AV valves, so mitral and tricuspid valve. So it forms this figure of 8, and aortic valve, you can see it is situated that is wedged between these two. But what happens in the common AV valve defect, common AV septal defect, this is the common AV valve ring, and the aortic valve is sprung. So it is placed anteriorly. It will lead to the elongation of the LVOT or gooseneck deformity. So anterior displacement of the aortic valve creates an elongated, so-called the gooseneck deformity of the LVOT, more frequent when the AV valve orifice is present than when there is common orifice. Discrete subaortic fibromuscular ridges, septal hypertrophy, abnormal left AV valve caudal attachment can exacerbate subaortic stenosis. Obstruction may develop de novo after initial repair of the AVSD and closure of the mitral valve clefts. The LVOT obstruction often is progressive, so this is very important. So here again the morphological specimen that's showing the same thing. This is the posterior mitral leaflet, and this is the apex. The distance between this and apex to the aorta is almost same in the normal heart, while in the AVSD the distance between the posterior leaflet and apex is 20 to 25% shorter than the distance from the apex to aorta, and there is scooped interventricular septum. This will lead to the elongation of LVOT or gooseneck deformity. Associated lesions, tetralogy of Fallot, DORV, pulmonary valve atresia, anomalous pulmonary venous connection, atrioventricular valve abnormalities, LV hypoplasia, and coarctation of aorta. So come to the radiology. So there is cardiomegaly, prominent pulmonary vascular margin, and arterial enlargement. This is more or less like the large AST. You can see the mild cardiomegaly, there is increase in the QP, otherwise there is no other significant finding. ECG. So the main ECG finding is due to the AV node is displaced posteriorly near the orifice of the coronary sinus, and his bundle is displaced inferiorly along the inferior rim of the septal defect. This results in left axis deviation in the frontal plane QRS. So prolongation of PR is occurring up to 70% of the patient is primarily due to increased intra-atrial conduction time. QRS axis ranges from -30 to -120, but mostly it is -30 to -90. RV volume overload results in RV hypertrophy and some variation of the RS-RDS pattern, and a patient with significant mitral regurgitation may have left ventricular hypertrophy. So this is the general ECG representative of the partial AVCD. This ECG shows sinus rhythm with the left axis deviation and superior QRS axis. Special forms of partial AVSD. There is malaligned atrial septum or double outlet of right atrium or DORA. So deviation of atrial septum to the left of the atrioventricular junction. Both the right and left atrioventricular valves are visualized from the right atrium, which is connected to both ventricles through a large primum AST, and there might be common atrium. So now come to the complete AVSD. So complete AVSD carries with a large septal defect with interatrial and interventricular components and a common atrioventricular valve that spans the entire septal leaflet. The common AV valve has the 5 leaflets. Beneath the 5 commissure are 5 papillary muscles. 2 papillary muscles are often rotated counterclockwise in the LV such that the posterior muscle is farther from the septum than normal and anterior muscle is closer to the septum. This papillary muscle in conjunction with the prominence of the anterolateral muscle bundle may contribute to progressive LVOT obstruction. So this is the morphological specimen showing. Here you can see the atrioventricular junction. There are 2 distinct AV junction in the normal heart. This is the tricuspid valve, this is the mitral valve, this is the left AV junction, and this is the right atrioventricular junction. So and there is a normal offsetting that we have discussed, and this is the atrioventricular membrane. While this is the common complete balance AVCD, and you can see there is a common atrioventricular junction. This is the consistent or constant feature in all forms of AVSD, and there is this canal that is comprised of the atrial septal defect, primum atrial septal defect, and large inlet VSD. So this is atrial component, this is a ventricular component, and you can see this is a common AV valve leaflet. So these are the other morphological specimen. The top left is you can see this is the RA view. And RA and RV free wall is removed. This is a large canal. RA-RV is dilated and RVH is there. This top right is the same specimen but shown from the left side, and LA and LV free wall is removed, and this is the large canal. This is short axis view. This shows the 5 different leaflet. This is the superior bridging leaflet. This is the left molar leaflet. This is the inferior bridging leaflet. This is the right posterior leaflet. This is the right anterior leaflet. So this is the Rastelli type A. You can see the clearly superior bridging leaflet. Cord is attached to the intercrest of the interventricular septum. This is the apical 4th chamber view. This is showing the large AVSD. RA, RV is dilated. There is RVH. This specimen shows the unbalanced form of the AVSD in which RV dominance is there. You can clearly see RV is dilated and hypertrophied. LV is hypoplastic. Interventricular septum is bulging toward the LV. This specimen show there is a right atrial isomerism. So both are behaving like the right atrium, and there is L looping of the ventricle. This is apical 4th chamber. This is morphological RV, and there is large canal. This is most commonly associated with the heterotaxy or more complex cyanotic CHDs. So now come to the Rastelli classification. So what is it? It is depend on the how the anterior bridging leaflet and cord are attached, or you can say the superior bridging leaflet. So Rastelli type A superior bridging leaflet is divided and attached to the crest of the interventricular septum. There are multiple chorda. In type B Rastelli, it is partly divided and not attached to the crest of the septum. Chorda attached to papillary muscle in the RV, usually on the septal surface. While type C, not divided, not attached to the crest of the septum, is called the free floating. Chordae may attach to the papillary muscle on the RV free wall. So here is a cartoon representative of the same. This is the superior bridging leaflet. Okay, so it attached to the crest of the interventricular septum, you can see, and here you can see the superior bridging leaflet is attached to the RV side of the papillary muscle, and it is here type C, it attached to the free wall. So whenever this happens, like in type A, there is the size of the, here is the comparatively size of the superior bridging leaflet and right anterior leaflet or dextrodorsal leaflet. So in type B, what happens, this size of this bridging leaflet increases and correspondingly decrease in the right anterior leaflet size, and in type C, the right anterior leaflet is very narrow or very small, while the superior bridging leaflet is very large. It is this free floating. So Rastelli is the most common variety, 70 to 75% of the cases. Rastelli B is like 20 to 25% cases. Rastelli C is the next common, and Rastelli B is around 5% of cases. Clinical manifestation. So this behaves like a large ASD and VSD combined. So the patient is having the tachypnea and failure to thrive occur early in the infancy. On physical examination, you can see the hyperactive precordium. There is loud first heart sound, second heart sound is quite variable, and there are murmurs, loud holosystolic murmur that is heard in the low flavor sternum border or cardiac capacity if the left atrial valve regurgitation is present. A separate crescendo decrescendo systolic ejection murmur is heard over the upper left sternum border as a result of the increased pulmonary blood flow. Mid diastolic murmur due to increase in the pulmonary blood flow through the common AV valve. This is the echocardiography of the common complete balance AVC. Here you can see this is apical 4-chamber view showing the common complete balance AVST. You can see the RV is mildly dilated, RVH is there. This is Rastelli type A defect. This is balanced ventricle. The dense chord is attached to the crest of the interventricular septum. Here you can see the large ostium primum AST. There is large inlet VST, and also there is a large ostium secundum AST. This is the echocardiography representation. This is subcostal short axis view. You can clearly visualize the 5 different leaflets. You can clearly visualize the 5 different leaflets here. You are going to see it. Okay. This is subcostal long axis view. It clearly this is Doppler interrogation. This clearly shows there is large ostium secundum AST and ostium primum AST. There is LV2RA jet also. This is apical 4-chamber view. This is Rastelli type A common complete balance AVST. There is large. This is the canal. This is the common AV valve junction. There is large primum AST, large inlet VST. This is Rastelli type A. Chord is attached to the interventricular septum, and both ventricles are of equal size. The same apical 4-chamber view with Doppler interrogation, you can see the multiple regurgitation. There is a moderate left AV valve regurgitation, there is moderate right AV valve regurgitation. Here you can see the clearly 2 jets are there. The left jet is mainly from the left between the left mural leaflet and inferior bridging leaflet. The medial jet is between the superior and inferior bridging leaflet, and this jet is between the right anterior and right posterior leaflet. This is example of intermediate AVST. Here you can see there is a moderate inlet VST and moderate primum AST. This is still images echocardiographic. This is showing different Rastelli type A, B and C. You can see the clearly the superior bridging leaflet is attached to the crest of the interventricular septum by dense chordae. This is a Rastelli type B, in which this is partly attached to the interventricular septum, and mainly it is attached to the RV side, to the RV papillary muscle on septal surface, and this is the free floating, and the chordae is attached to the RV free wall. This is still image of the complete AVSD, the same thing. This is ASD, this is VSD. This is systolic image, this is diastolic image. This is still image showing the systole and diastole, the free floating superior bridging leaflet. This is Rastelli type C. Here is the echocardiographic image of the Rastelli type C. Here you can see there is a large inlet VSD, there is large prime of ASD, RV is hypertrophied. This is free floating bridging leaflet. There is no caudal attachment to the interventricular crest and it is attached to the RV free wall. Now come to the concept of the balance or ventricular dominance. When there is like both of the AV valve is draining more or less to the single one of the ventricle, then it will lead to the hypertrophy or dilatation of that ventricle, and other ventricle is underfill or hypoplastic. So here you can see the LV is this is LV dominance, this is RV dominance, corresponding echocardiographic images. So how can you define that thing? By doing the echo you can visually also see, but by AV valve index you can define the area of the, like what is the AV valve index? When you calculate the left AV valve area and divide by the total common AV valve area, that is known as the AV valve index. So balance AVCD, like roughly that should be 0.5, but 0.4 to 0.6 is considered the balanced AVSD. If it is less than 0.4, then it is unbalanced AVSD. So X-ray, this is the 4-month baby with a common complete AVSD. Here you can see the cardiomegaly and increased pulmonary plethora. This is a Down syndrome patient with the AVSD. You can see the huge cardiomegaly and there is pulmonary plethora. ECG again is the same as the partial AVSD. There is a prolongation of the PR interval and superior or northwest QRS axis. Most patients having an axis between -90 to -120, RVH or less commonly LVH. So this is the typical ECG of the common complete AVSD. This is in the 3-month-old complete AVSD patient. There is a left axis deviation and right ventricular hypertrophy. You can clearly see. This is again the 2-month-old baby, no failure to thrive. This ECG is a sinus rhythm with superior QRS axis. There is RVH that you can see dominant in the R wave in the V1 and dominant negative S wave in the V6, and there is a positive T wave in the V1. Clinical course, this patient behave like large ASD and VSD combined. So patient has the failure symptom during the early infancy. Patient require decongestant therapy during early infancy, and surgical correction is usually done by 3 to 6 months of age. In the Down syndrome patient, you may require early surgery because of the inherently lung pathology in those patients. So in summary, in all the AVSD patients, you need to classify it properly, either in the partial, transitional, intermediate or complete AVSD. Then you have to classify it by like Rastelli type A, B or C, and then balanced or unbalanced AVSD, and then proper delineation of the AV valve morphologic, left or degree of AV valve regurgitation, interpapillary muscle distance, and in any abnormality like double orifice of left AV valve. Then associated cardiac defect like in type C or Rastelli, it may be associated with complex variety of the other heart problems and syndromes. Then patient require timely surgery according to the types and defect and regular follow-up afterward. Thank you very much.